I want to thank you all for coming tonight, taking some time out for a true legend in chiropractic. You guys are really going to enjoy this. So I'm going to introduce Dr. Kelly Brinkman, and she's going to open up the program for us.
Hi, thank you so much. I'd like to welcome everybody to this very special event. Having known Dr. James Cox for over 27 years, I can attest that he's a wonderful person who's contributed to our profession that's phenomenal. I'm very excited that you can experience a bit of his deep love for his work and our profession, as well as learn about the legacy of his table and his technique. But before we get started, I'd like to thank Dr. Dana Underkoffler for making this event get started. It was her creation and her thought, and for Dr. DeBono and Dr. McDonald for making it possible. It's a real honor to be here, and it's a dream for me to be here. In addition, I'd like to thank Julie, his daughter, for all she does to support us instructors and the field doctors, and for managing her dad's body of work. And I'd also like to thank all of you for coming today. Your presence honors a man who's been in service to our profession for over 53 years, and he's still going strong. His current project right now, he's got 40 doctors throughout the United States that are trained by the NIH to work in a study that's going to eventually evaluate the failed back surgery patients treated with the flexion distraction technique. So hopefully that project will get underway soon, and by the time some of you graduate, we're all going to benefit from that research. But he's one of the few people out there who's ever developed a technique, a table, written textbooks, and validated his work with both clinical and cadaver research, and one who's lectured worldwide to both the chiropractic and the medical professions. So each one of us here has benefited from his efforts, and those who come after us will as well. I first met him in 1988 when he came here to Logan, and I just have to tell you that it was a life-changing moment for me. I remember he was in the gymnasium, which is now Charlie's Grab and Go, and he stood there with the table. He had a microphone around his neck. The lavalier didn't work. I don't know if you remember this, but they had a regular microphone. They had to duct tape it on us, tied, in order for him to give his presentation, and he was absolutely enthralling. I just remember his enthusiasm for the adjustment, the power of chiropractic, what we can do for our patients, how we can open up and distract the joint, and I was just mesmerized by his excitement. And if there was one word that I would associate with him, is excitement. That day he talked about how exciting it was to treat his patients, the power of chiropractic, the power of decompressing the dorsal root ganglion for patients with chronic pain, and I was really hooked from that day on. So when I listened to him, his enthusiasm and passion was to be drawn deeper into my own commitment of chiropractic, and I'm sure the same thing will happen to you today. For those of you who may not be familiar with his work, we're going to show you a quick introductory video so you're kind of familiar with it. But it's safe to say that his research and table have had a phenomenal effect on the profession. His technique is in the top 3 used by our fellow chiropractors across the country, and his work is often quoted and used in physical therapy research and even used in the physiatry department up at Mayo Clinic. And you know someone's special when people from other countries fly in for his care, and even when a past pope is called for an adjustment. So after the video, Dr. Kettner will say a few words, and then Dr. Jim's going to take over, and we'll have a short break halfway through. So it's been an honor to be here today. It's been an honor to share your work here at Logan for the last 27 years, and enjoy the evening. Thank you.
Hello, I'm Julie Cox-Sid. I'm the coordinator for Cox Technique, educational seminars, the website, practice support materials for patients and doctors, communication for the Cox 7 table manufacturer, Haven Innovation, and content director for the Cox Technique Complete program. It's a pleasure for me to work with doctors, both certified and non-certified in Cox Technique, patients, researchers, and all those involved with the technique. The information online about Cox Technique, or flexion distraction as it was first coined by Dr. Cox in the 1960s, has grown. We would like to contribute to this information with some official demonstration of Cox Technique, its protocols, goals, and research. Here is Dr. James Cox.
This is what Cox Technique looks like. Hello, I am Dr. James Cox, developer of Cox Technique flexion distraction and decompression spinal manipulation. Note that Cox Technique is gentle, it's smooth, it's rhythmical, it's doctor-controlled, and specific level applied to the patient's spine. Whether treating the low back, as I've been doing here, or treating a cervical disc herniation in the cervical spine, the treatment is always the same. It is smooth, rhythmical, slow, and specifically applied. In the years since I introduced and first called this technique flexion distraction, Cox technique has grown in the science, acceptance, and effectiveness. I proudly share it with my chiropractic colleagues, of whom 64% report that they use Cox flexion distraction in their clinical practice. In light of this proclaimed usage, I strive to establish Cox technique responsibly with research, education, and documentation. With the National University of Health Sciences, the Cox Technique certification course offers training in the proper application of this technique, and nearly 2,000 chiropractors have taken advantage of this certification opportunity. I am humbled by each certified Cox Technique doctor's dedication to caring for spinal pain patients in a classic chiropractic way using their hands. The certified Cox Technique doctor uses his or her trained, experienced tissue tension senses to monitor this adjusting procedure at all times. The certified doctor knows the importance of careful tolerance testing throughout the application of this treatment. Yes, it looks easy. I hear that all the time, but it is the balance of the hand pressure and the table motion that requires skill and experience to optimize patient clinical outcomes. The certification course we mentioned ensures that the certified doctor experiences the proper force application. Further, Cox certified technique doctors know Protocol 1 and Protocol 2, which are the divisions of types of patients with back, arm, and leg pain which we treat. Certified Cox technique doctors fear not the worst spinal conditions, such as spinal stenosis with a disc herniation, or post-surgical continued back pain, or the simpler, yet no less painful degenerative disc, sprain and strain, or facet arthritis. Certified Cox doctors practice in the knowledge that there are documented clinical outcome studies which detail the number of days and the number of visits required to attain maximum relief for their patients. That there are also clinical guidelines that lead the doctor to gauge patient response and to know if that response is expected and adequate to meet the patient and the doctor's clinical expectations. There are federally funded research studies that show the millimeters of pressure that Cox technique drops inside of your intervertebral disc as we apply technique as you see here. Again, in treating the thoracic spine, you'll note that again the doctor's contact is specific. It's gentle. It's a smooth movement of decompression with the bottom section of the table. It is very specifically applied to the given level of the spine that is creating the patient's pain.
I invite you to visit these websites for more information on the Cox technique, its certification course, research and referral directory of certified doctors, the Cox table by Haven Innovation, the preferred instrument for Cox technique spinal manipulation, and Cox Technique Complete, the clinical practice program for flexion distraction practitioners' use to tell their communities that they are the spinal pain relief specialist to see. Thank you for your interest in Cox technique.
Good evening, ladies and gentlemen. It is my honor to introduce Dr. James Cox, whom I have at least twice introduced for the annual Logan Howe oration when he joined Terry Yoakum and myself to give a fitting tribute to Dr. Joseph W. Howe at the first and the 10th Logan University Howe oration. Dr. Cox, you have once again been extended an invitation, and also again, this tribute to an icon of the chiropractic profession. But today, Dr. Cox, you are the icon and the focus of our attention. We recognize your vision, courage, tenacity, and intellect across your extraordinary and accomplished career. Your career developed and evolved as a chiropractic clinician to that of a scientist and an academician, to what I respectfully refer to as the holy triad. That's W-H-O-L-E, as in Whole Foods. And you are a respected clinician, prolific academician, and a researcher. And you're at an echelon of professional quality that really engenders respect from colleagues, from patients, and from scholars across the globe. So how is excellence in a career scaled or measured? Well, we can sample from Jim's curriculum vitae. There's a prominent publication list, but what does that mean? Well, it means, for example, while submitting many, many publications, he displayed the personal tenacity to move onward through what are often critical, distasteful, and disagreeable issues and views posed by journal reviewers, reviewers of federal research grant applications Dr. Cox has been frequently involved with. But he came back for more, year after year, accepting this as a requirement and a contribution to the clinical community. Once again, referring to Dr. Cox's curriculum vitae, the awards section. Well, it's certainly appropriate in breadth and depth for an icon of this profession, and this event, this tribute, is one award, one added to a list of many. But Dr. Cox, be certain, this tribute from Logan University reflects an expression of a level of gratitude, admiration, and respect that covers the entire chiropractic profession and beyond. Dr. Cox has provided important clinical research insights, made contributions across multiple disciplines, including biomechanics, diagnostic imaging, diagnosis and treatment of spinal syndromes, and the use of manual therapy with the Cox Flexion distraction in chronic pain management. Chiropractic radiology has been an enduring resource for our profession, embracing the integration with mainstream medicine into what may be termed integrative medicine. And so we honor you, Dr. James Cox, for your integrity, your professional standards without compromise, and your unrelenting pursuit of excellence. Please welcome Dr. James Cox.
How many of you remember John Boehner? He was a Speaker of the House, right? How many of you remember what John Boehner said on national television when he retired that position? Any of you? He made an indelible impression on me. He said, when you do the right thing for the right reason, you get the right result. That's why we're here tonight. I'd like to share where I've come from, because many of you are going to travel the same road. And if I can take some bumps out of it, all the better, right? So we say, where did all this come from, Jim? I mean, why didn't you follow your dream of going back to Fort Wayne, Indiana, having a nice practice, live your life, love your family? Because it wasn't meant to be. I graduated from National College of Chiropractic in 1963. None of you were even thought of at that time. And I was valedictorian of the class, and it didn't take me long to realize that that didn't mean anything. Because Einstein's right, the knowledge acquiring period begins upon graduation from the school. And Carnegie said that successful people in all walks of life never stop acquiring specialized knowledge in their business, trade, or profession. And those who are unsuccessful make the mistake of believing that the knowledge acquiring period ends upon graduation, when in fact it only begins. Let me illustrate. I graduated with this man. Any of you know who that is? He was a faculty member at this school. Ron and I studied many a night together. I loved the man. He was a great human, a very kind, the kind of a man you'd take your mother to if she were ill. Ron Grant. When I was in school and an intern, I noticed something that at the time I was too smart to see. I noticed that when we had severe bad backs come in with radicular component, that this man, who was my chief of staff, Dr. Floyd Blackmore, who Joe Howe knew very well as well, that he would take these bad patients into another room where there was this weird-looking table. I'd never seen anything like that. And it was called a McManus osteopathic table. And Dr. Blackmore was clinic chief at 20 North Ashland, and he would take these patients that were bad because he was an osteopath as well as a chiropractor. And my first naive exposure to greatness was him. But like I said, I was too smart to pick up on it. Do you get what I mean? And so when I graduated, I went back into Fort Wayne, and I went in with my stepfather, Dr. John Rodman, who was also a DO and a DC. And when I went back there and practiced at the O'Neill Ross College of Chiropractic in Fort Wayne, one of my very first patients was a 24-year-old beautiful young girl who came into the clinic like this. Now, in 1963, we were taught that a disc didn't have a nerve supply. Yes, indeed, you could root around with a rongeur. You could rotate and twist, and it wouldn't bother them. Well, today, what do we know about a disc sensitivity? It's the most pain-sensitive tissue in the low back. Kuslitz, Orthopedic Clinics in North America, volume 22-2, okay? So things have changed greatly. When that young lady came into me, I did what I knew in 1963. I put her on her side, I brought one leg up, I made this contact, and I thrusted. And I called that a lumbar roll. And I'm not here to be offensive, only informative. She screamed in pain. They took her to the hospital, and she had surgery. And I was devastated. I said to my father, I said, I'm going to leave the profession. I can't do this to people. There's got to be something better. And here's the words he said to me. He said, son, you may well be in the way of learning. And I said, it's been a long trip. And he introduced me to a book by Edith Ashmore, a lady osteopath, A.T. Still, Alan Stoddard, And the man you see on the screen, his name is John McManus. John McManus and his wife Lulu were at the Kirksville College of Osteopathic Medicine. And someday I hope to sit down and have a nice, loving discussion with John McManus, because we share many commonalities. McManus had this table. It was an osteopath. It was a surgeon table. It made into an ear, nose, and throat chair. It was a gynecology table, and it was a manipulation table. So I went up in Battle Creek, Michigan, and bought one of these from the widow of an osteopath. She said, "Son, I won't pay you to haul it out, but you can have it if you'll take it out." What a change in life. I brought that thing home. I put a room with pillows and straps, and this room began to look like the rack of a torture chamber, because I'm stretching backs. But you know what happened? I learned the law of the joint. The osteopath says the law of the joint states that the key to manipulation is that we stretch tissues. We'll talk more about that. But the other thing that happened, I have never, ever since that day had him carry a patient out of my clinic. Not once. So two of my colleagues, George Catter, Jerry Orr, they had bad backs, and they came over, and I treated them with this thing. And they said, "Jim, what is this?" I said, "Well, I don't know. I mean, this is how I'm treating bad backs." And they said, "Will you teach us?" And I taught those too. And for the first time, I became what people accused me of being an entrepreneur. I didn't even know what that was. You know? So I trained these two doctors, and pretty soon I said, "This table's not going to cut it. Can you put together a chiropractic table like I was trained on, like Zenith high-lows and tables like that, with this?" And I found an engineer who did that, and thus was born what was called the chiropractic McManus table. We were off on a new road. And it was quite an exciting trip. This is John McManus at the time of his death in 1934. Do you know that John McManus was so disgruntled with osteopathy because they took the course not of manipulation but allopathic medicine? Do you know what I'm saying? So what did he do? He went to National College of Chiropractic and became a chiropractor. He actually taught, and I never knew this, he had taught at National. And here's one of the statements that he made. He said, "There's a lot about how the medical men tread on our toes." Then at the last AOA meeting, says it's the same old story. Osteopathy discovers the scientific truth. Allopathy rediscovers it many years later. And although our principles and achievements are not known to them, they blindly assume to disregard all rules of the game. And I want to tell you, that's continuing today. That's continuing today. I'll show you articles, and you know it is true, that the New York Times or the Des Moines paper, all newspapers will write an article about back pain. And they'll mention manipulation, and they totally eliminate the people who do 90% of it in this country. That's you and me. Have you ever noticed that? Anybody? No? I see it all the time. They totally annihilate our involvement. And I aim to pound so hard that they have no choice but to recognize what my profession does as spinal specialists, because that's what I think we are, spinal specialists. I like this picture. That's Henry Ford, Thomas Edison, Warren G. Harding, and Harvey Firestone sitting down talking about things. That's what we're doing today in our profession. And when I saw that picture, I said, you know what? It's time that this moves into my profession. Next year, a year from last month, I'm holding a multidisciplinary clinic in Fort Wayne, in which I'll have an orthopedic surgeon who did the federal studies on Maverick discs and replacements in the spine, a neurosurgeon that we work with in treating even cervical myelomalacia cases, which we'll talk about tomorrow. We'll have spinal cord implants. Are you familiar with those? Now, instead of a spinal cord implant, they're what? Dorsal root ganglion implants, right? More effective than cord implants, although with limitations. We will have a urologist talk about S3, stimulation for incontinence, and you will deal with incontinence if you treat spinal stenosis. And then because all of this causes depression, we'll have a psychiatrist speak on how do you and I, in daily practice, deal with depression. Because anyone who has pain for 2 months, if they have a normal brain, are going to be what? Depressed. And you and I must cope with that. And then I will have the University of Pittsburgh there, and Michael Schneider and his physical therapist. And yes, there will be physical therapists there. You must grow up to realize that spinal manipulation is not the sole domain of this profession. We must excel to maintain the leadership. And we will discuss what the University of Pittsburgh does in the combination of chiropractic and physical therapy and treating. So that's what I mean when I look at this picture. Brilliance in one place for you to learn from. Einstein put it this way: the world we have made as a result of the level of thinking we've done thus far creates problems that we cannot solve at the same level of thinking at which we created them. There's a lot of thinkers in this room. I think I see on your signs here that you're creating leaders. You absolutely must know that we need you. Stephen Pearl said that, talking about techniques in our profession, he said they've not fallen into the trash heap of chiropractic history because research has found them ineffective or unsafe, but because of, let me say, poor marketing or the changing tastes of the profession. And the most important thing, he said, as a profession, we have to be prepared to abandon ship if the ship is sinking. That is, if the evidence shows that there is a better way. Now, when we discuss distraction manipulation, I want to tell you this is not in competition with high velocity, low amplitude thrust. It is complementary to it. Do you get that? Because, young doctors, you're going to treat people that don't cavitate. They don't have any nitrogen in their joints. How are they going to cavitate? And if you persist in trying to cavitate a dish, a Kummel's disease, an advanced arthritic, a discogenic change, you're not going to get anything done. And the patient will be disgruntled with 3 people. Number 1, you. Number 2, the profession. And number 3, themselves for seed. You must be successful. So the change you want to see, Gandhi is right. Every one of us needs to practice. Whether you're speaking at the Rotary Club, in the hospital to a group of physicians, at an interdisciplinary clinic at the International Society of the Study of the Lumbar Spine, at the American Back Society, at the World Conference on Low Back and Pelvic Pain, wherever you are, you represent chiropractic. And the way you look, the way you talk, is the image of our profession. Joachim and I once spoke at the American Back Society. I don't know, we were asked to speak there, Norm. And I'll always remember this. Aubrey Schwartz, head of it, says, now, Terry, you're going to read these film. And Cox, you're going to sit on the panel. And Vert Mooney was the moderator. And on the right side were all conservative doctors. The Rene Calliers, Frank Bumfrey from Clinic, and I was there.
and on the other side, we're all surgeons. So in walks this orthopedic surgeon in his navy whites holding an armful of MRIs. And he puts them down and they throw them up, and Terry starts interpreting these MRIs. And Vermuni said this, he said, all of you to my left, you won't even have anything to say because all 8 of these cases are surgical failures and you're all surgeons. So he looked to the right, and you talk about anal sphincterism. He says, let's hear how the chiropractor would take on a failed back surgical syndrome. And you could have heard a pin drop. There's 1,000 surgeons and PTs in this room. And we discussed how we would treat this. And we went through 8 cases, all of them failed backs. Some of you will only treat people with unilateral railroad tracks on their cervical or lumbar spines. That means they're failed back surgical syndromes. But when we got done, I said to Terry, Terry, and you ask Joachim, he'll tell you, this is a true story. I said, Terry, can you imagine? Both of our fathers were put in jail for practicing medicine without a license. And the next generation, we're speaking so these same guys can renew their license. Do you understand what I'm saying? Now, what will happen in the next generation? Well, this institution stands as the example of what the next generation will be. That's all of you. What you have in store for you, you can't even dream about. Like, I would never have dreamt to speak to 1,000 surgeons about chiropractic. What you will do will be far greater than anything that Joachim and I, if I'd even say my friend Norm Kettner, have done. Okay? So, I thought this was an interesting thing to share with your young minds. This came out of Chiropractic Manual Therapy 3 years ago. And Cheryl Hawk was on this paper. I think you're probably familiar with that research lady. They talked about chiropractic students. What do you expect out of your profession? Interesting question, eh? Well, she put it this way. Said the majority of students would like to see an emphasis on correction of vertebral subluxation, while a larger percent found it is important to learn about evidence-based practice. These 2 key points may seem contradictory, suggesting cognitive dissonance, or perhaps some students want to hold on to the traditional theory, that is, subluxation-centered practice, while recognizing the need for further research. But I say to you, who cares? We'll call it segmental dysfunction. We can prove that in several ways. I was on the original committee in 1972 when we went into Medicare, and we said there were 17 types of subluxation. Now, you don't like that term? Okay, I don't care, you know? Doesn't matter to me. We'll call it segmental dysfunction. What do the osteopaths call it? They call it the osteopathic lesion, right? Whatever it is, it either moves too much or too little, you know? And I can define it with the instrument. But our premise as spine specialists must continue as we perform the research that documents our clinical attempts. This paper just came out last month by Bowden et al. Says, here's the reason that chiropractic demands the best doctors. You. Here's the reason. This is published in Spine Journal last month. He said that patients who are going to surgeons need the very best surgeons that they can get, and those going for conservative care need the very best conservative doctors that they can get. That's you. There is no substitute for excellence, and many of you are going to be those excellent doctors. Where do you turn for low back pain? Well, here's the Harvard newsletter. Kowalski wrote there, for your edification that since you shouldn't try to diagnose your own back pain, make your first call to a professional who can assess your problem, such as a primary care physician or a chiropractor. That comes out of Harvard Medical School. They don't put that in a lot of the articles I read in the New York Times. How about you? Right. It goes on that there, at Beth Israel Deaconess Hospital, Dr. Robert Schmerling says spinal manipulation is first-line care for back pain. 8.5% of adults in the United States seek chiropractic care. It will not be long until that number doubles, and you won't be able to handle the influx of patients. The epidemiology in low back pain in young and middle-aged adults, 70% of these people experience lumbar pain, 61% neck pain. It is said that today in teenagers, 58% of teenagers show disc degeneration and have back pain. And yet, they are not trained in ergonomics. They certainly have never had a spinal examination like you and I can perform. Lanier writes that the alterations in muscle activity, and this is something I'm really interested in, the relationship is perhaps best defined by the afferentation theory of cerebral arousal. When you stimulate the 2 to 4 millimeter thick cerebral cortex, in chronic people, the cortex atrophies. Memory loss takes place. Cognition decreases. And as these papers show you, when you reduce chronic pain, the cortex perfusion improves and the cortical thickness returns. Is that a powerful tool for this profession? These are published papers. This guy goes on to say that agents or maneuvers that produce muscle stretch. Do you do that? I do it all day long. Muscle stretch or contraction or directly stimulate muscle stretch receptors will produce cerebral stimulation. What this paper's saying, and you've got a man at genius level at this in Norm Kettner, every time you and I give an adjustment, we are creating afferentation. We are lighting up the somatosensory cortex of the brain, which results in pyramidal stimulation of the cortical spinal tract that carries down serotonin and endorphins to the site of pain to stimulate the internuncial neuron between the small unmyelinated C fiber and the large myelinated A, beta, and delta fibers. You know what I'm saying, don't you? You should. Here it is, Simonowitz. The dorsolateral prefrontal cortex, thinner before treatment of chronic low back pain, showed increased thickness after treatment. These are the things that when you treat a patient, you can hardly contain your excitement, right? Just thinking about cerebral perfusion and return of cortical thickness. Dorsolateral frontal cortex, thinner before, more so afterward. Chronic low back pain patients, and here's the paper. Everything I give you is referenced for your information. Did you see this paper? Simon wrote in Physical Therapy, chronic low back participants have lower working memory performance and higher pain, catastrophizing. People will tell you that there's something, doctor, when you treat me, I can think better. I concentrate better. I feel better. A paper telling you that chronic low back pain interferes with cognition. Neck, this paper says spinal joint dysfunction may be involved by a hyperactivity in the regional sympathetic nervous system. I'd like to just summarize this whole thing this way. We live in a hypersympathetic atonic society. We live in stress. We live at a time in which when the head flexes 30 degrees forward, instead of weighing 11 pounds, it weighs 40 pounds. We sit that way, we're under stress and tension. And in chronic back pain, the sympathetic nervous system dominates the parasympathetics. And what happens when that takes place? Well, we get irritable bowel syndrome, we get high blood pressure, heart arrhythmias, memory loss. And remember, so important, so much written in the literature, that the vagal, parasympathetic, anti-inflammatory effect is something you and I must accomplish in every adjustment that we give. You must calm the sympathetics and stimulate the parasympathetic vagus nerve. We'll talk more about that. Motor cortex stimulation induces pain relief. Why is that? Well, when you and I touch a patient, when we talk to them, we are creating lateral spinal thalamic and posterior column stimulation that creates the production of serotonin, endorphins. It causes the mu and kappa receptors in the raphe magna of the medulla oblongata to produce endorphins that will follow down the corticospinal tracts to the internuncial neurons within the substantia gelatinosa of Rolando, within the posterolateral gray matter of the spinal cord. Right? You follow that? That's the thoughts that go through your mind when you touch a spine. I want you to note this paper. The American Pain Society, Chow says, and I'm only telling you what he said, he recommends the American Pain Society and the American College of Physicians both say that spinal manipulation is first-line care for back pain. Who is that? Well, there's about 300 of us here, okay? We're being told that you are the future of treating the human spine and its conditions, okay? Look what else they said, and I didn't write this. I'm just sharing it. You don't have to agree with it. They said the prolotherapy, that is the injection of formalin into the fascia of the lumbar spine, facet joint injection, intradiscal steroids, and percutaneous intradiscal cooking the nerves in the intervertebral disc are not effective. I didn't say that. I offer that for your erudite consideration. But in clinical practice, you really see it's true. Patient with chronic low back pain related disability should first consider spinal manipulation as a conservative treatment. This is published in European Journal of Physical Rehabilitation. Flexion distraction and drop techniques. This is written by O, came out of Journal of Physical Therapy Science, April of this year. Yes, the physical therapists, if you read their journals, they're talking about using this work, flexion distraction. They won't put my name there, but if you read the references, we're in the references, okay? Physical therapists are very aggressively using this technique, and here's just one of the papers. This one done by O. They're saying that it's very effective in treating female patients with lumbar intervertebral disc herniation. Doctor, if you don't approach intervertebral disc herniations of the lumbar spine very carefully, you get bad outcomes. Rudy Cashman, a neurosurgeon who speaks at these conferences, and he'll speak this fall, next fall, he said three things. He said, disc cripple people, disc cripple people, discs cripple people. And boy, is he right. That's why the treatment must be very specific, very well instrumented, and oftentimes interdisciplinary. This is Dubourg. I put this ceiling on, this is on the ceiling of my bedroom. I can't get over this paper. See what you think. Dubourg wrote this paper in Spine Journal in 2002. He said, and there's a long list of surgeons on this paper, he said the return of motor power in the lower extremities is better treated conservatively than surgically. Now, I want you to think about that. And when you get the answer, will you write the old guy and tell me? That's a very stimulating paper. It haunts me all the time as to why that is. I got some ideas. What do you think of that paper? Anyone want to comment on that? Well, could I comment on it? When you get a patient come into you with foot drop, or they can't walk on their toe, because they got L5 or S1, chemical or mechanical compression. What do you tell them? Here's what I tell them. That Ewan wrote in Neurology, Volume 44, that in 3 years is the time it takes to attain maximum return of motor power and sensory innervation. And at that time, 75% is the average return, not 100%. That's what I tell them. People seem to respond to that because I've told them something that's factual and something that they can believe that I, as a clinician, can document in the literature. Ligner writes, and then how about this? Did you see this in Germany? They're so in favor of spinal manipulation that medical doctors are taking a 2.5-hour course, not 2.5 weeks, 2.5 months, or 2.5 years. Did you read it? A 2.5-hour course in spinal manipulation. And they're amazed at how much relief they're giving people with manual therapy. It led to faster pain reduction, reduced opioid use, and improved functional capacity. That's the popularity. That's what McManus was talking about. The osteopath developed the good things, and the medical doctor sits around and plucks the low fruit. So, we like evidence. Evidence-based things, very simple. It means you have clinical expertise. That means the doctor's really good. You have research, and that results in what? Patient preference. That's what makes people come back to you and me in our profession. That's what evidence-based research is. What is minimal clinical improvement? That term mean anything to you? When I came out in practice, and probably a part of my anal retentiveness was that I thought everybody should get 100% well. In fact, in our work, we teach that we expect 50% relief in Protocol 2, people without radicular pain, or 50% relief in 2 months of people who have Protocol 1 radicular pain, upper or lower extremity. What is considered today the smallest change that is important to patients? 30%. That shock you? It shocked me. 30% improvement means that it was worth implementing that form of care and that the patient was satisfied. Doctor, many of the people that we treat never get 100% relief. I had trouble accepting that. I want to share with you that and urge you to accept it. For many people, 50% relief, being able to walk without a walker, to lift their grandchild, that's 100% relief, you know. Very few people get 100% relief. And once you damage a nerve, Mother Nature never forgets a debt. She continues to collect for the rest of your life. So I think that in this study, in 609 patients, at 12 months, 55% improved in both the total sample and the sciatic group. You'll see that about half of the people, and then get this statement. In the literature, if you look at spinal surgery, about 1,175,000 done per year in the U.S., the work of Atlas from Harvard, for example, will tell us that half of those people will have relief. It doesn't mean that they're 100% well. They get somewhere from 1 to 100 VAS score improvement. But the other half, and the other half is going to haunt you as clinicians, are the ones that are the same or what? Worse. Many of these people have POUR, P-O-U-R. What is POUR? POUR is postoperative urinary retention. That's why next year I will have Don Urban speak to you about incontinence. You will have to deal with incontinence in spinal stenosis. Today, there are modes that are 100% successful in stopping urinary and anal rectal incontinence. Did you hear that? That's something I bet you'll remember and want to learn more about. What about drugs? Well, here's Bart Coe's. Look at the drugs. This is a well-done paper and published in this Pharmacopoeia journal here. He says in this study that acetaminophen and Tylenol, basically for back pain, forget it, you know. NSAIDs, very small effect. Muscle relaxants, probably cyclobenzaprine. Flexeril is one of the most useless drugs you'll ever see. What is it? It's a muscle relaxant, you know. Tricyclic drugs, the number of people that we see who are on Cymbalta, serotonin reuptake inhibitors, Elavil, depression pills are tremendous. And yet, in some studies show that they give no benefit. Coe says no benefit. And yet some people think that when you calm down their sympathetic nervous systems, they feel better. Depression is something that is a big battle for you and for me as clinicians. People get depressed. We must be able to cope with that. But when you get down through all of these drugs, and you look at some of the strong opioids, the results are small to no benefit at all. Did you know that? Small to no benefit at all. In New Hampshire, the study done with chiropractic treatment by Whedon, did you see a tremendous drop in opioid use following chiropractic manipulation for back pain? Very low quality evidence that the NSAIDs are any better than a placebo. How are NSAIDs supposed to help? Well, very briefly, I'm sure you know this, but it turns me on to think about it. You've got arachidonic acid, right? It converts into thromboxane A2, then leukotriene B4, right? And what does it? Cyclooxygenase. So medical doctors give you an NSAID, which are Cox inhibitors, no relation to me. And what are they supposed to do? They're supposed to block the action of cyclooxygenase from converting arachidonic acid into leukotriene B4, which then converts into what? M1 and M2 cytokines. M1 are anti-inflammatory, M2 pro-inflammatory. So you set up a battle of inflammation that happens to be around an intervertebral disc herniation. You and I have a tremendous battle on our hands as a clinician. Pregabalin, the studies come out that pregabalin, which is, and Neurontin, which is gabapentin, you familiar with those? No value. No value. I mean, there's the papers. I wouldn't dare say anything to you that isn't referenced. This is the New England Journal of Medicine last year. And you will see people come into you on these anticonvulsant drugs. Isn't that what they are? When they didn't work for the temporal lobe of epilepsy, they said, we got to do something with them. We'll treat back pain. Am I right, Dr. Portwood? You know? So you and I see them all the time. If you do have to use the two, pregabalin is far less toxic than gabapentin or Neurontin, however. But neither one rave reviews. Pregabalin was not more effective than the placebo. Friedman writes, among patients with acute, non-radicular low back pain presenting to the emergency room, they find that cyclobexamine, that's Flexerol, or oxycodone were no better at functional outcomes at 1 week, and they do not support the use of those medications in back pain. Doctor, you go to an emergency room, what are you going to get? You're going to get Flexeril, cyclobenzaprine, and maybe even an opioid drug to get you out the door before they can get to you. Chiropractic positive treatment results. More than 3/4 of chronic low back pain people will go to a complementary alternative health care provider, the biggest one of which is you. Stagnant physical therapy referral rates. Did you ever think about this? How bright the future is for you and for my profession and your profession? Look at this, doctor. This is published by Zhang in Spine Journal, May last year. Stagnant physical therapy rates. In a study of 17.1 million PT referrals out of 17 million patients, the number of people sent to a PT for musculoskeletal conditions by a general practitioner was 10%. 10%. What do? They give you drugs. When the drugs don't work, they order an epidural steroid, then a surgeon's involved. That's the usual flavor of this thing. But only 10% of people with musculoskeletal back pain are referred even to a physical therapist. This study came out that 6,904 referrals to a physical therapist from 776,000 GP encounters equated to 0.8% of them sent for conservative care. Do you feel the excitement here? That as you and I publish and we show our results and we sit in our neighborhoods and in our hospitals and in our clinics and we show our results, you have nowhere to go but up. You getting this point? Manual therapy using joint mobilization and flexion distraction is considered an effective intervention in treating people with chronic low back pain. I want you to notice who published that. Choi in the Journal of Physical Therapy Science. Physical therapists are using high velocity, low amplitude. They're using Cox technique. I'm told that 1/3 of my textbook is bought by PTs and MDs. Sometimes they say, well, Jim, you shouldn't allow that to happen. Oh, really? What would you like me to do about it? No. 90% of patients with neck or low back pain visiting a chiropractor have a 30% improvement in 6 weeks. But look what else it said. Read the whole thing. And they show a trajectory of symptoms characterized by persistent or fluctuating pain of low or medium intensity. Only a minority either experience a rapid complete recovery or develop chronic severe pain. Not 100%, not severe crippling pain, somewhere in between, demanding ongoing supportive care. How many of you read the Nordic Paper that just came out? Well, the Nordic Paper was done by LeBoeuf et al., and it said in a comparison study that people who had maintenance chiropractic care after they attained maximum medical improvement had lower recurrence and lower cost of health care. That's the Nordic Paper. Look it up. Do you have a journal club here? Look up the Nordic Paper. It'll be quite stimulating to you. So 41% of 262 chiropractic low back pain patients reported to be covered. Here is another paper. See the name LeBoeuf? LeBoeuf, it's a lady researcher, a Danish woman, in chiropractic manual therapy, talking about recovery and why maintenance care is beneficial. So spinal manipulation can be used to strengthen muscles. I don't know whether you happen to have seen this paper, but spinal manipulation can be used to strengthen muscles as shown by anterior tibialis muscle strength increase following spinal manipulation under EMG studies. I didn't write it. I'm sharing it for your erudite consideration as one of the big benefits of chiropractic manipulation. One of the things that flows through your cortex every time you touch a patient. Mobilization induces, I didn't write this either. It was written in Journal of Bodywork Movement Therapy last year. Mobilization induces more pain relief interaction than does high velocity, low amplitude technique. I didn't write it, but I will tell you this, that rather than to fight a joint trying to cavitate that it can't cavitate, put it through physiological motion under decompression, and after some of that treatment, cavitation, which was not possible, does what? It takes place. Thank you, doctor. I like it when somebody thinks the old man said something right. So, at 12 months, the proportion of patients reporting recovery ranged from 27% for severe sciatica to 45% for mild sciatica. That's a paper about individual low back and leg pain under treatment with conservative care. Now, we far exceed that, which I'll show you with our research studies shortly. How long should a patient undergo conservative care before surgery? Of course, in the absence of progressive neurological sign, which is not very often as a clinician you will see. You'll see it's 8 to 12 weeks. In other words, for 8 to 12 weeks, and our criterion published in Topics in Clinical Chiropractic, volume 3.3, says that you treat for 3 months, and you can treat them up to daily for severe disc lesions. Doctor, if in that time you achieve 50% improvement, you've exceeded two things. Number one, you've exceeded a surgical outcome. And number two, you've prevented a patient from having to go to a surgery. Because by that time, if you get 50% improvement, and by now you've switched them from passive to active care, and in a very aggressive rehab program, this patient's going to do very, very well. In fact, if you look at the statistics, what percent of people go to surgery? 2%. Are you happy treating 97% of the spines in this country? The answer is yes. So, I want to talk about cooking nerves, radiofrequency neurotomy, cooking about 90 degrees centigrade. At 2 years, 40% of the patients maintain a 50% reduction in pain intensity. Doctor, I share with you to remember that. You're going to read papers in which 40% of the people maintaining a 50% relief was excellent clinical outcome. You must be realistic in what the expectations are in our clinical practices. This is realistic expectation. You need to know that, in my opinion. Here's a paper that shows that findings confirm that when you first see a patient, you must lay out the goals. I don't have time here for this, but we give them a book. I describe to them everything from a disc herniation, spinal stenosis, pregnancy back pain, facet syndrome, short leg, subluxation, transitional segment, spondylolisthesis. And I expect them to understand fully what is in their spine and also what is their responsibility in getting well and staying well. And then if they have an upset, it's not my fault, it's theirs. And they'll all tell you, Doc, I did the wrong thing, I did this or that or the other thing. Flexion distraction, spinal manipulation is used to relieve an L4, L5 disc extrusion, compressing an L5 nerve. This paper was published in Journal of Chiropractic Medicine. Hublik writes, conservative treatment for recurrent. This paper says that when you treat a person who's had back surgery and they come in with recurrent sciatica, you should be the first line treatment of that patient. And if what you do doesn't help, they can still look to a second surgical opinion. But for cerebrating humans, I find that the ones who've had back surgery usually want to do everything they can to avoid another. They're probably the best patients to treat. Functional outcome of non-surgical and surgical management for degenerative lumbar scoliosis. And believe this, my colleague, when these people come in with scoliosis, the thoracolumbar spine, they have those large osteophytic ankylosis on the concave side of the curve. Guarantee you don't PA thrust them. You don't lumbar roll them. You use this technique. They are very challenging. And if we had time, I'd show you how we treat them supine, side lying, and prone. Okay? All three methods of manipulation. Lumbar rotation manipulation increases intradiscal pressure in the annulus and moderately degenerated disc increases, suggesting the need for caution. What is the maximum rotation? The Volvo award-winning paper of Hookins and Hickey. What's the maximum rotation of L5 on S1? 3.6 degrees. So if it's herniated and sick, why would you try to rotate it to 20 or 30? And I've got that answer to that. Making acupuncture and chiropractic care more easily acceptable can lead to more satisfaction for patients and providers and provide important input for policymakers. This is what's being written in the literature to encourage people to see you and play. Okay? This was published in BMC Family Practice, March of last year. These results suggest that neuromobilization, the big kid on the block today, how long are nerve roots? Nerve roots are only 12 to 15 millimeters long. I'll show you the DRG is 3 times bigger than the combination of both nerve roots combined. We'll be talking about that shortly. This is an update. I don't know if you saw this or not, but it's done by Wong. Wong, and an update of the Bone and Joint Decade Task Force says that manipulation, mobilization, and clinical massage are effective interventions for the management of neck pain. It also suggests that electroacupuncture, strain, counter-strain, relax massage, and some passive physical modalities like heat, cold, diathermy, water, and ultrasound are not effective and should not be used to manage neck pain. Now, I'm not asking you to agree with that. Frankly, I don't agree with it. But it's what's published. It means that you and I, to refute papers like that, must show why they're wrong. Okay. Spinal stenosis in this treatment. I mentioned to a group of the young students here before that in practice, 1 out of 4 of the people that you and I treat account for 90 to 95% of all the cost in human suffering and dollars in treating spine pain. Did you know that? Tim Carey, University of North Carolina. The Journal of Occupational Environmental Health, volume 3910 by Owens. The majority of the money goes to that 25% of the patients. And what are those? Spinal stenosis. Spinal stenosis is phagocytosing our country because of people in my age group. You have no choice, well, you have a choice. Don't treat them or treat them, but treat them very effectively. And in the treatment of spinal stenosis with our work, I consider this the myocardial infarct of chiropractic practice. This patient walks in with pain shooting down one or both legs. They can't move. They're frozen in position. And they say, I want you to set my hips so I can finish loading my furniture and move to Tennessee today. Well, unless you and I have an agreement, probably 2 people are going to be very disappointed today. So when we look at this patient, we looked in clinical biomechanics of the spine by Punjabi and White. And just in very, very briefly, I'd just like to share with you a couple of facts to think about whenever you and I attend a human spine. One of them is that these nerve roots, the dorsal and ventral rami, are about 12 to 15 millimeters long. That's not very big. You probably never thought about how small they are, but here's the dorsal root ganglion. Dorsal root ganglion is 3 times larger than both of those roots combined. In a normal, healthy disc, the dorsal root ganglion fills half of the osteoligamentous canal. You used to call that the intervertebral foramen. No. The job of the chiropractor is to destenose the dorsal root ganglion. That's what you and I exist for. Remember Chitani? Chitani said, when you compress the DRG, you develop radicular component. When you compress the DRG, you develop radicular component. When you compress the DRG, you develop radicular component. I dream about that kind of crap at night. But the intervertebral disc here is supplied anteriorly by the gray rami communicanti right off the sympathetic gangliated chain. The posterior disc here is supplied by the sinovertebral nerve. And people like Nikolai Bogduk, New Zealand, Woods tell you that in disc degeneration, and you've heard the term discogenic pain, right? In chronic degeneration, the gray rami will grow as deep as into the nucleus pulposus of the disc. Now you got to think back, 20, 25 years ago, we didn't know that. We were taught that a disc didn't have a nerve supply. None of you are old enough in here to remember those days. But today we know how pain sensitive it is. And this gray rami here not only innervates the intervertebral disc, but it also supplies the anterior dural lining of the DRG, the ligamentum flavum, the synovial lining of the facet joint, along with the dorsal ramus of the spinal nerve. But my doctor, under chronic back pain, a very interesting phenomenon takes place in the human spine. Namely, that the nerve supply begins more and more gray rami communicantes to the DRG, to the synovial lining, to the periosteum of bone, and to the nerve roots themselves. So that with chronic pain, a normal nerve can be touched and it is not pain sensitive. V, I come up and I treat trigger points on your shoulder. You say it feels good. Keep it up. Am I right? But what if your skin were sunburned? The work of Ian McNabb. Now you'd say stop. Am I right? That's the way the nerves are that you and I as clinicians are dealing with in clinical practice. The typical patient that you will see who comes in with low back pain, you'll treat 2 or 3 times and they say, Doc, I feel, you're great, doctor. I feel good. A year later, that same patient comes in and says, well, doctor, that pain in my back is down into my leg, down to my knee. Now you treat him 8 or 10 times. Oh, Doc, you're great. 2 years later, they come in, and here's what they say. They say, doctor, that pain's all the way down my leg, and I didn't do anything to cause it. Why do they say that? Because in that period of chronic pain, the gray rami communicantes have grown directly from the dorsal root ganglion into the disc, into the periosteum, into the ligamentum flavum, which now begins to thicken. The ligamentum flavum normally 3 to 4 millimeters thick can get up to 10 or 12 millimeters thick, right? And this patient, because of that increased sympathetic innervation, becomes more and more vulnerable to pain with less and less irritation. Does that make any sense to you? That's why Long at Harvard wrote that the average patient going to spine surgery is 41 years old. They've had 10 years of recurrent back pain, which results in this ultimate symptomatology that leads them to surgery. It's going to be the same thing with you, doctor, as a clinician. All the excitement, it will become very great when you see these people. Does that make any sense to you? Well, let's look at it a little more, okay? This is dorsal root ganglion. If you imagine the dura is my coat and my shirt's the DRG. Between here are 2 things, cerebrospinal fluid, veins, and arteries. 50% of the nutrition of the nerve complex, its trophic supply, is CSF, and the other half is what? Blood flow. You note how huge the DRG is. There's a sensory root and a motor root. Now, young doctors, you're going to see, and you probably already know, those of you who see patients, that it's far more common that we see pain with no motor weakness. Am I right? Why is that? It's because the sensory root is 3 times bigger than the motor root. So when you have chemical or mechanical compression, which is first affected? Sensory root. It takes, and we'll talk about Takahashi in just a moment as to why that is. Because your mind is a computer, doctor. When that patient walks in, you're going to diagnose the level, the type, and the size of the disc before you even know their name. That's the excitement of life. That's the 4th most exciting thing in life. Because distraction manipulation and neuromobilization. This is Don Murphy. When Don Murphy is treating spinal stenosis, he published this paper. Don Murphy is at the Rhode Island Spine Center in Rhode Island, a very fine doctor of chiropractic. And look at the technique that they used and the clinical results that they got. You see that they use distraction manipulation, neuromobilization. Doctor, you're doing neuromobilization every time you distract or physiologically place faucets through their physiological range of motion. And the treatment of 57 patients with lumbar spine stenosis showed the mean patient-rated percentage improvement from baseline to the end of treatment was 65%. Is that a good clinical outcome? Surgeons would love to get that. And this is a well-done paper by Don Murphy and his group. It's published in BMC Musculoskeletal Disorders. Decompression surgery for lumbar spine stenosis over age 80 shows pain improvement, drop from a VAS of 7.2 to 4.5. Doctor, if you look at any of these studies, 50% improvement is considered what? Minimal clinical improvement determination, good clinical outcome. Be easy on yourself. Don't do like I did and expect 100% relief, because it's not going to happen. No more than the people keep doing their exercises. No more than they keep drinking Pepsi-Cola all day either, you know. You know what I'm saying. No conclusion in this review whether surgical or non-surgical treatment is better for individuals with lumbar spine stenosis. I like to share papers like that with you. This paper, if you look, was published in 2016 in Spine Journal. High rate of, you'll note here that no side effects were reported for any of the conservative treatment, but 10 to 24% of surgical people had what? Adverse outcomes. At least we know today that our profession is first-line treatment for back pain. We can treat 8 to 12 weeks. If we get 30% improvement, where are we? We're in line with minimal clinical improvement determination. Is that helpful to you to know that? Saved my life as a clinician. This is that interdisciplinary conference I told you about. I'd like to invite all of you there. Next year, we're going to have Rob Shugart is an orthopedic surgeon that did the fairly funded study of putting Charite and Maverick discs in the cervical and lumbar spines. He'll be speaking. Urban is a urologist that will talk to us about incontinence. Dozier's a neurosurgeon. He's the one that I'm treating cervical myelopathy patients with at this time. Nolan is a spinal cord implant surgeon. George Yoakum will present spinal stenosis cases at that. Souls is a PhD, will speak on depression. Kurt Olding will speak on balance. We are presently through an IRB at Miami University in Oxford, Ohio, to do a study on balance. Another thing, and very briefly, you will deal with falls, big time. As people age and their dorsal columns atrophy, they develop loss of coordination, falls, and the big thing from a fall is a broken hip, and high percentage of these people are dead within what? 2 years. You have no choice but to listen to Kurt Olding talk to you about this IRB. We're seeking the approval to do the study right now on Cox technique of balance improvement under 2 months. We'll treat them for 2 months and recheck their flexion extension and lateral flexion movement with an instrument to measure proprioceptive balance, okay? And then we will also have this is Rudy Cashman. He's a neurosurgeon in Fort Wayne. Lee Hazen is a resident that I trained, practices in Temecula, California. He's an integrated practice with a group of medical doctors, and he does all of the triaging of spine pain patients there. And then we will have University of Pittsburgh come, and Schneider will talk on Sunday morning right here on interdisciplinary learning training at the University of Pittsburgh with chiropractors and physical therapists combined in treating patients. Like it or not, that is the wave of the future. Get used to it. Spinal stenosis and our treatment. 58, look at this study. 58% of patients who were told to have surgery under a multidisciplinary study were told you don't need surgery. And of the others, 28% of them were told that the surgery recommended was the wrong surgery. It's astounding. What's the source of that paper again? Oh, Yamandala, out of Spine Journal, January 2017. I show people papers like that. Sometimes they don't know, should I come to you or should I go to surgery? Show them the published papers. If they cerebrate, they'll make the right decision. Vagus nerve, I'm excited to talk to Dr. Kettner. I stimulate vagus nerve on every patient I treat at the celiac plexus or at C4. The vagus nerve is the anti-inflammatory network in the human body. And I just wanted to share that with you. So we look first at hypotheses on this. And this is a paper, that I think I'll save this for our discussion, Norm, tomorrow. It's a futuristic chiropractor. It's written in August, just 2 months ago. And it's talked about the immune system as being the seventh sense. The sixth sense being balance, and the seventh sense being the immune system. The affect of the sympathetic nervous system speaking to monocytes. That's another subject which we'll talk more about tomorrow. Next part of our discussion will be the research end and the clinical application of the low back. We'll do cervical spine tomorrow. But our future, in my opinion, will be fully exposed when research documents our premise and our clinical outcomes. So for many years, from about 1970 through 1992, I actually wrote, out of my own ignorance, I would write grant proposals to the National Institutes of Health. And I was told no in every way you can imagine, you know. And then in 1992, a very interesting thing happened. The federal government, United States Congress, said that we will fund chiropractic research as long as it is done in collaboration with a medical or an osteopathic institution. Now, having been denied so many times, I thought, wow, this is the opportunity. And then another thing happened, that Dr. Ram Goudavali graduated from the University of Cincinnati as a biomechanist. He did his master's at McMaster University, and then after graduating from University of Cincinnati, John Triano hired him at National as a researcher. And we talked at National, the three of us, and said, yes, we will try for one of these federally funded grants. It was through the Health Resources and Services Administration of the Department of HHS. And in order to get the grant, they said we had to do a pilot study. We had to submit something that HRSA could look at and determine if this was worthy of the taxpayers' money. Okay? And so we had to raise $150,000 to do that. So 100 chiropractors gave $100, and I took care of the rest. And we, one frozen morning at 1 o'clock in the morning, we had spoken at O'Hare Airport at a hotel there, and we wheeled a 57-year-old man, died of apoplexy, across the frozen parking lot at National into the radiation lab. And I dressed in lead and performed Protocol 1 on an L4 disc level. And we found that the intervertebral disc spaces increased, facet joints moved, and that we could increase interspinous space. And we submitted that, and lo and behold, HRSA said, we will fund chiropractic research, but you have to do something for us. We want you to show us in a human spine what happens when you perform this type of Cox manipulation. So, of course, we said, oh, sure, we'll do that, and didn't have a clue how. But when they said that it would be done in conjunction with a medical or an osteopathic school, Dr. Gudavalli knew Dr. A.G. Patwarden, who was the chief of research at Loyola Medical School and Heinz VA Hospital. And I remember the day we met. Alexander Gadayam is the chief of spine surgery at Loyola. And Ram explained what we wanted to do, and Patwarden said, I see no reason we shouldn't do this. And we did. It was set. After all those years, decades of being told, no, you're not worthy, all at once, it opened. And here's the first study, my colleagues, for your erudite consideration. This was the pilot study on the 57-year-old man. This is Loyola Med Center, where we do this research. I can tell you that never did I ever dream that we would do this in my lifetime. That's me arriving with my briefcase. And behind there, that's Heinz VA Hospital. Have any of you ever seen Heinz VA Hospital? It's huge. It's built on an airstrip. It's about 2.5, 3 blocks long, am I right? You stand on one end, it looks like infinity at the other end of it. And that's where we did these studies. And another picture, and that's Heinz VA Hospital. This is a tremendous institution. They bring vets there from all over the war zones for help. And this is Dr. Ram Gudavalli. Many of you have not known him, but you will meet him in the future. Dr. Gudavalli is the man, the brilliant science behind my work. I may stand here and rant on, but it's only because of the brilliance of the people like Dr. Gudavalli and the PhDs at Loyola Med School and Heinz VA Hospital, Palmer, and National, all working together, that we accomplish what you're about to see. That's where academics overcomes political infighting. Do you understand what I mean or not? Okay. So that's Dr. Gudavalli and myself. This is on the far side. That's Dr. Robert Vining from Palmer, Dr. Mike Seidman from Palmer, Dr. Gudavalli, and myself. This is a C-arm. When we did the cervical studies, we would take plain x-rays before, during, and after the distraction spinal manipulation. This is the team that did the cervical spine. This gentleman here deserves credit. His name is Robert Havey, and he wrote all the software for the studies that we did at Loyola and Hines VA Hospital. In this, in Hines VA Hospital, if you've ever been there, and you can only get in under lock and key. I mean, it's a very well guarded place. They have more toys than I'd ever seen in my life. For example, in the room next to us, they were doing Charite and Maverick discs. The people that manufactured them were doing the studies there. They even had John Kennedy's disc there that they had tried, and it was marvelous. But down this hallway here, it's lined with research papers like these, and these are 3 of our research papers hanging in the hall in Hines VA Hospital. Now, they also have a big stamp, and don't get angry at this, it's big red letters, says bullshit. And when they read a paper that they don't agree with, they stamp that paper, okay, that way. And ours are not stamped thusly. So we have papers on your profession at Loyola Med School and Hines VA Hospital hanging in that hallway. I see the excitement in your eyes. Then this is Dr. A.G. Pat Warden. I gave him a copy of my textbook. Did I bring a textbook, Julie? That's the 7th edition of the book. I asked everybody, because I have to read it all the time, I asked all certified doctors to read this book 3 times. This is the book. It's the 7th edition, published by Williams & Wilkins, Lippincott. And I don't want you to think I make money. If you look at the back, all royalties go to research. All royalties to research. There are 10 authors in this book. And I suggest that, I know it's in your library, I've seen it there. And I'm sure Dr. Brinkman recommend. You ever stop to think how fortunate you are to have Kelly Brinkman here? This woman has stood up against opposition to bring this technique here. I don't say that lightly. You're fortunate to have her as an instructor. She's a great person and an excellent doctor of chiropractic. How many of you have taken her class? Look at that, Kelly. Look at those hands. That's what they think of you, dear lady. She's been to Fort Wayne, studied with me so many times. She's taught with me at my side. We're like Theodore Roosevelt Rough Riders. Do you know what I mean by that? But that's A.G. Pat Warden. Halfway through the studies, Pat Warden and G'dayam said, I can see that we will need chiropractors at Hines VA. That's the kind of results you were showing them. Let's go on. So, how was it implemented? Well, HRSA, they told us, and Dr. Gudavalli was the principal investigator, and after 30 years of being denied, we finally got a research grant. And I do feel like a rough rider. It's not the guy in the arena that gets knocked down, bloodied, and gets up again. It's not the guy watching him, it's that guy that really counts. That's what Theodore Roosevelt described as a rough rider. So after we sent in and submitted our pilot study, HRSA came back, and they actually came on campus. If you remember, Bill Clinton was the president of the United States. Donna Shalala was the head of HHS. And Sean Maroney was the representative for our study. She came on campus at National and Loyola. And they granted this money. Incidentally, there were 5 of us who would go up to Loyola and Hines and spend 3 days in doing these cadaver studies that I'll show you. We never got 1 penny, never got 1 penny of any of the research. It all goes to the institutions. I want you to know there is no money in doing this as a research clinician, okay? But having said that, this was the amount of money they got awarded by HRSA. These were the team that we had. On the far right is Geraldine Cambron. She's from National. Dr. Verbose is from Loyola Med School. This is Dr. Pat Warden, Dr. Ambarush, University of Illinois, James Baker, myself, Dr. Gudavali, and that's Scott Chapman, who practices at Braintree Hospital in Boston. And he wrote the chapter on rehab in the textbook. This was a research lab at National that was built just for this study. This is a Cox flexion distraction table. That's OptiTrack, 3 infrared cameras here. And these infrared cameras measure forces. These are force plates here that measure the XYZ forces that you and I are applying. This was very crude. Today, when I demonstrate to you, you get real-time feedback on the newtons or force or pounds, whatever you want to use, that you are using in a PA and a long y-axis direction as you apply long y-axis decompression spinal manipulation. So these were the original force plates. These are 9 unembalmed, non-rigored cadavers that are either treated immediately upon death or frozen and thawed. And this is all under OSHA regulation. OSHA would come into the clinic and observe this treatment. So we treated them with Protocol 1. These, the little dots that you see here, those are transducers that are placed into the right posterolateral nucleus pulposus of the disc, and they measure the intradiscal pressure changes that take place when we do Protocol 1 and Protocol 2, which you'll see shortly. These are rods placed into the lamina pedicle junction at L4, 5, and S1, and attached to those rods are these receptors. And into the disc are placed transducers. These are little thin wires that go into the nucleus pulposus in order to measure the changes in intradiscal pressure as you and I perform spinal manipulation. How many of you read the book Orthopedic Medicine by Sir James Syriax? In that book, do you remember? He said that, I think that intradiscal pressures drop under spinal manipulation. But who proved it? You did in this study. Be very proud of what our profession accomplished here, showing intradiscal pressure drops for the first time with the spinal manipulation. And so we had these receptors at the end of these rods. We had the transducers into the nucleus pulposus. These receptors here receive the beam from the 3 infrared cameras of OptiTrack, so they measure within a 100th of a millimeter of motion of the spine, so that you'll see the results in a moment. After the spines are removed, they are digitized after we're done with the study. And this is finite element analysis, in which you can perform the same study on the model of the spine on a computer that you did on the whole body. That's all computerized work. Frankly, I don't understand all that, but I don't have to. It's like Henry Ford. They said, well, Henry, you don't know anything about this. He said, well, I don't have to. I got a lot of people that know about it for me. And there's no way that one person could know all this stuff. It's so huge. So these are digitized spines. The day will come, I want to see it, in which this spine will be on an MRI, and you'll see the spine you're treating move. You get that or not? That would be someday, wouldn't it not? So when you do this technique, which we will show, there are 5 things happen in the human spine that we documented per HRSA's request. Number 1, we increase the intervertebral disc space height. We convert a stenotic canal to the best of our ability into patency. People oftentimes say, Doctor, it would feel good if someone just pulled me apart. I say, I'm going to pull you apart. And they'll show you something else we tell them shortly. This paper done by Chung, I don't know that you saw this, but papers like this keep me up at night. This was in Radiology Journal, which is a very good journal, am I right? Published in 2015. Look what Chung said about this. He said that continuous distraction on a herniated lumbar disc and surrounding structures results in change in disc shape, disc reduction with opening in the intervertebral disc, reduction of herniated disc volume, separation of the disc and adjoining nerve root, and widening of the facet joint. Disc reduction gives the ratios, and these are the very changes that Chung showed on MRI that you and I showed real time. Do you follow me? Okay. Published in a very universally top journal in medicine radiology. This documents what you and I contend as chiropractic manipulating physicians. I don't know if you ever read Geyring and He, but these are thoughts that have to go through your mind every time you distract and treat a spine. Geyring said this: if you compress the disc of rabbits for 28 days, they degenerate. And they distracted them for 28 days, and what did they do? In their words, they regenerated. I didn't publish it. They published it in Spine Journal, volume 31.5. He did the same thing, H-E-E. Kuo, how about Kuo's paper? These are just substantiations of what you're thinking about when we go to this instrument and treat disc herniation. The mechanics of distraction on the porcine model, you run out of lawyers, you use pigs. The biomechanical benefits included disc height recovery, foraminal enlargement, and intradiscal pressure reduction. That was a paper published in Spine Journal in 2014. Now, if I didn't know that, my excitement and confidence in treating the patient would not be as great. But knowing what's going on here and here, published in erudite journals. Ron Evans spoke with me in Florida. You know who Ron Evans is? He wrote the book on orthopedic testing. He said this, and I'll never forget it. Julie, tell me if I'm wrong. He said, never worry about trying to impress a patient with your qualifications because they're sold on you when they come in the door. And what sells them? Your reputation. You know what they say about reputation? Reputation is what other people think of you. Character is what you know about yourself. I have a big sign that says character counts in my room. So Kuo went on to show that not only do you increase disc space, increase foraminal area, and drop intradiscal pressure, but look at the bottom of this slide. I didn't publish it. It's verbatim out of Kuo's paper out of Spine. Distraction treatment is effective in enhancing nutrient supply and promoting disc cell proliferation of degenerated discs. Another thought for you, my colleague. Every time that you and I distract, neurally mobilize a nerve root, and place faucets in the physiological range of motion, we are creating afferentation. We are stimulating circulation through the end plate. Discs get nutrition two ways, am I right? 70% through the end plate from the cancellous vertebral bone through the end plate, 30% from the anterior and posterior disc. You think that's not true? Well, it's Knockamson, Spine Volume 1, Number 1, page 59. Classic paper for you to read. Every time you treat, those thoughts are going through your mind, you see, with great excitement. And that's what Kuo showed. So what do we do when we treat? We put people on the glycosaminoglycan content of a disc. What's glycosaminoglycan? It's a mucopolysaccharide that imbibes fluid to 9 times its own volume. And what is it by chemistry? It's chondroitin sulfate. So we give people chondroitin sulfate as we distract. And what does Kuo say? you stimulate imbibition of fluids into the disc to help, if possible, to stimulate regeneration and at least to stop what? Degeneration. Remember Pierce, Journal of Orthopedic Research 5.2, what did he say? He said when one disc is degenerated, it's not just that one, it's all the discs in the spine which show the loss of chondroitin sulfate. So disc degeneration really isn't just a local traumatic event. It can be called a systemic disease. Some of you won't sleep tonight thinking about that statement, am I right? None of you nod your head yes, but this was Kuo's paper. Choi says, a compression of decompression therapy in general traction found no statistical significance in clinical outcome and depression. Comparison of the use of Saunders. Since I developed this, how many of you have seen Saunders work? Chattanooga, they've come out with copies. They're about $16,000 a piece. I went over to Parkview Hospital. They have 2 of them. I said, what do you do with those? He said, we put patients on them and stretch their hamstrings. And then Miss Lemon said, would you teach us how to use them? I said, no, not today. You know. Oh. Okay. I like to talk a lot. But let's show you the technique. So there's 5 things that happen. 1, you increase disc space. You increase foraminal area by 28%. You put faucets through all physiological ranges of motion. And 5, you create afferentation, that is, normal excitatory impulses of the lateral spinal thalamic and posterior columns to the somatosensory cortex of the brain. So my patient, one of you, come on up. When you use the instrument, always set it at about 6 degrees of flexion because all of your bad patients are going to come in some degree of flexion. If you ever have one come in like this, I'd like to co-author the paper. If you'll lie with your eyes. You have to adjust the headpiece. This is a brand new instrument. It's never been used. So I look at you and I kind of gauge what I think will work. And if that doesn't work, you can adjust it yourself. Lie with your eyes right here. Now when she, is that okay? When you're treating low back pain, we always want the ASIS right here about 1 inch ahead on the thoracic piece. That places the lumbar spine right here where I have complete control over both protocol 1 and 2, every movement of the spine. Before we ever treat any condition, we always tolerance test. Tolerance test is 3 things. Number 1, it's central. And always, when you use this, always set the instrument so that you don't have to do any work. You can use it with a little finger. It's like power steering on a car. When you treat, we always do central tolerance testing. That is, we'll contact L1. We'll move to the taut point. That is all the slack. We enter what we call the barrier of elastic resistance, where we take all the slack out of the disc, the facet, ligaments, and tendons, and we're ready for entry into the paraphysiological zone, right? So, if you'll watch this screen on the top, you'll see there's a light blue line. That's my pressure on the spine in the long y-axis cephalad force. The dark blue line is the distraction force applied with the caudal section. Are we together? So I contact L1. Now, I'd just like you to note something. Look what happens to that pressure. This line. Can that be any bigger? I shouldn't be choosy, right? But I wanted you to see, they're going to make it bigger? Oh, yeah. Yeah. Now, you're going to watch me. You're going to see this long y-axis force. It says -6 pounds. When I distract, you're going to see me first bring this to the taut point. Just putting my hand on the spinous process will begin to raise that long y-axis force. Then we go to the taut point. That's the point at which we make all of the joints tight at that level. And it's from there that we apply long y-axis distraction and decompression of the disc. So if you'll watch up there, I want you to notice that when I just make my contact on her spine, are you okay, doctor? Watch what happens to the line. You see it raise? The dark blue line and the light blue line? Do it again. Now watch, when I just make my force, you see how it increases? Now, the next thing we do is we bring the patient to the taut point. That is, I've taken all the slack out of all the joints, the knee, the hip, the faucets. And now I apply 8 pounds of distraction. And 8 pounds is the goal that we want you to learn. And it looks like this. Are you okay, doctor? Now, if you look at my force. There I am at 1, 8, 1 to 8. Now, do you note how smooth, rhythmical, oscillatory, almost sensual that looks? You get it? That's the force that you want to learn to apply. That's the force that we teach you to apply, 8 pounds to a lumbar segment. And that's the force we use in treating spinal stenosis, whether that stenosis be to a disc herniation or what? Degenerative disc and facet disease. Again, therefore, and you will learn this. You've got the instrument. You can learn. 2 weeks ago, we taught national interns this technique. It's so simple. It used to be that we had to say, when you do it, does it feel like when Jim did it? Now we have an objective tool. Pretty cool, right? So this would be, again, and let's take the most common, one of the 2 most common things you and I treat, L5-S1 disc herniation, okay? Here would be the contact. Thenar on the spinous process. Can I just do this? You all right? She'll tell you, and when you make that contact on the spinous, the dorsal ramus is very tender. You spread the force of your contact throughout your entire hand and fingers. I contact L5 spinous. This long necktie serves as a good purpose. It tells me when I'm right over and on the midline. Because you don't want to be distracting a joint like this or this. You want a straight cephalad y-axis force. So I'm right over, I move down, taut point. Let's start again. Can you see that movement, doctor? When I move to the taut point, right there, everything is taut between her spinous processes. So as I apply long y-axis distraction, it looks like this. Now you can read the force. Are you okay, doctor? That's the force. Now she'll tell you that's a very loving, controlled force. It's not bombastic. It's very gentle, very smooth, and very rhythmic. And that's the force we want you to learn, 8 pounds. See it? Can you see that line over there? Tells you exactly how much force you're applying. Yeah, who's doing that? Me. Good girl. And after a while, you can do that. You can tell me what pounds you want. And having felt the habitus of my patient, that is the degree of rigidity or flexibility, you can reproduce the pounds just from your tissue tension sense. You name the pounds, we'll give you the delivery. Okay? Now, can I show visit one?
Yes. For the y-axis only?
No, I want to show circumduction, lateral flexion. Okay. Now, in treating a disc herniation, protocol 1, we only use flexion distraction. But once the patient has achieved 50% relief of sciatic or femoral radiculopathy, they become a protocol 2 patient. You okay, doctor? Protocol 2 is by far the most common technique you're going to use with Cox work, because most of the people you see do not have true radicular pain. What is true radicular pain? It's pain that extends below the knee. It's isolated to a specific dermatome. The straight leg raise is reduced by 50% or more on that side compared to the normal side. They have 2 or 4 neurological orthopedic signs positive and or a positive MRI or CT, okay? Most of the people you treat when you begin will be protocol 2. They don't have true sciatic radiculopathy, so you're going to use the movements that I'm going to show you here as measured in newtons or pounds of force and the degree of lateral flexion and circumduction that this patient is able to elicit. You can make a record of this, a printout on day 1. You can redo it in 2 or 4 weeks to show what? You guess what you'd be showing? Increase in range of motion. What are the 3 things that must happen in order to have a successful manipulation? Wong said, number 1, you must increase range of motion. Number 2, Beatty said you must stimulate circulation through the end plate from the cancellous vertebral bone into the intervertebral disc, as shown in diffusion imaging. And then number 3 was Kuo, that we must show that we can stimulate nutrition into the disc itself. The majority of the people that you will see will be protocol 2. Therefore, as we show you here, we release the lateral flexion lever on this instrument. I contact AL4. First of all, I apply long y-axis distraction. And incidentally, you can see the long y-axis shown. The degrees I'm using 4 degrees of flexion. Do you see it on the side? But then I institute, there you go. That's for your own edification. But then I institute, while under distraction, lateral flexion. And I can measure the degrees of lateral flexion that this patient can comfortably allow. So there, if you look, I'm going about 12 degrees. And I can increase as she begins to show physiological range of motion. Are you with me? And I can begin to increase lateral flexion and show that I can increase range of motion with spinal manipulation. Now, I'd like you to watch the next one. Are you all with me? This next one is called circumduction. In osteopathy, this is the most powerful movement that you and I can elicit to a triple joint complex. It's this. 2 contacts, I like to hold the spinous at the level I'm treating between my thumb and index. You okay, Doug? Circumduction is a combination of flexion and lateral flexion in a smooth, rhythmical, coupled pattern looking like this. This is the movement, my colleague, that once a patient can achieve full circumduction range of motion, you've got a pretty healthy articulation. Ma'am, your spine moves very nicely. Okay? I guarantee you, you put me on the table, or people over 50, they don't do this. Not at first go around, but they like this. Can I share this story with you? Don't get angry at me, but I know a doctor, a very good doctor, he has this in his room and he leaves the door open. You with me, Doc? And people go by and look at that and they say, what is that? And so my good friend Kurt Olding, one night he had a meeting. He invited the town of Minster, Ohio. Any of you from Ohio here? Go visit Minster, Ohio. Kurt Olding, what a tremendous physician. He's one of our instructors. But anyway, he went and he took about 50 slides on spinal stenosis. He showed the first slide, the question started, and he never showed another slide. I could probably have done that tonight. Just showed you technique. It's what you really want to see, isn't it? But the other stuff turns me on. But he shows this, Kurt shows this. People love to see objectivity. Can I show it to you again? I don't care what level. You pick the level. L1? Okay. L1. First of all, distract. See my measurement there of flexion distraction? You see I'm going at about, you see the measurement? The degree of lateral flexion or flexion extension I'm getting? I'm going about 15. Okay? But then I can do this two ways. Now watch this. I can lock the instrument and then apply lateral flexion at a single level. And I can compare right to left, seeking the goal of attaining normal physiological range of motion. And once it's that smooth, that's gorgeous there. Here's circumduction. And you can test your own skills. When you start, it won't be quite as easy as you might think to do this, but you'll attain it. Circumduction movement. Now, Joey, can I go back to the other one? When you become proficient, I mean really comfortable with the technique, and this is manual, right? This is all manual distraction manipulation. But once you really get comfortable with it, you'll begin to utilize automated distraction. That is, the instrument will do all the work, and all you're going to do is direct the vectors with your spine contact. Looks like this. Please observe how much stronger and how little automated distraction you must apply to get 8 to 10 pounds of distraction. Visualize, please. I make this contact. You okay, doctor? I move to the taut point. Now here's automated. Do you see how much stronger that is? You can see that I'm coming down here, and she'll tell you I'm applying well over 20, 25 pounds of distraction. So when you first start with a patient, you're going to do it manually. Then as they respond, you can move to long Y-axis distraction, and then long Y-axis and lateral flexion in a smooth, rhythmical, coupled pattern. But when you use automated, it's a much stronger force. Do you follow me or not? Okay. That's what it looks like. Now, conversely, when you do cervical spine, and when we teach this, there's a huge difference between teaching cervical spine and lumbar spine. Think about this. In a low back, all you and I have to contend with is a few scrawny sacral nerve roots, right? Everybody else is left home. We got a pudendal plexus here. We all know that medial disc and compressed pudendal plexus can cause what? Cauda equina signs or incontinence, Tarloff cysts. They can cause compression of the S2, 3, 4 nerve roots, resulting in pudendal plexus symptoms. What are those symptoms? Well, they're incontinence, they're urinary bladder infections, prostatitis, oophoриtis, salpingitis. Because the pudendal plexus innervates the penis and clitoris, it's responsible for the sexual response of man. So spinal stenosis affects impotency. It gives rise to the inferior hemorrhoidal nerve that innervates the colon and rectum and sigmoid. So people oftentimes will have a flare-up of hemorrhoids, or especially if they're on opioids and have constipation, right? It also innervates the perineal nerve, which gives rise to the long scrotal nerve, and guarantee you, you will not escape treating men with testicular pain. Not due to an organic disease, but due to what? Spinal stenosis at L4 and L5. So that's what you and I have down here. But when we move into a cervical spine, it's a whole different story. Treating a person with neck and radicular pain is a lot different in this way. At C5, C6, which is the most common disc herniation we see, is it not? It is. At this level, I've got a 7 to 8 millimeter spinal cord sitting here. If you have a 12 millimeter canal, you got 4 millimeters, which is filled with what? Veins, arteries, and lymphatics, and soft tissue. So as you notice, a small disc herniation in the neck can really create a whole lot of radicular component, right? Because there's not much room in the canal to accommodate a very large cervical disc herniation. So when you and I treat cervical discs, I teach you to start at no more than 6 pounds of distraction force. Now, tomorrow I'll show you the cervical spine research. We did the same studies on the neck we did the low back. And we will share with you what 6 pounds of force is. It looks like this. And I really hope that this makes an impression on you about gentleness. You can never be too gentle in treating any of these levels. I've never represented a malpractice case in which the person undertreated the patient. Always it was overtreating. So I relieve the long y-axis distraction. Contact the C5 arch. And observe carefully, please. This hand and this tiller bar move in parallel. Watch the force there that I'm going to apply. And first of all, I move to the taut point. Now, your neck's different in your low back, doctor. Whole different story. Now, I move to the taut point. Now I apply. Note. That's 4 pounds. Did you feel that? She cavitated. Her low back and her neck are like two different people. When I do motion palpation, I have much less range of motion here than her low back. And when I distracted, C5, C6 just cavitated, what you call popping. So again, that contact. And when you do this, you always lift with this hand. As you apply long y-axis distraction, you lift. Why? Because if you apply a PA force, you're going to increase intradiscal pressure. If you decrease lordosis and lift, you decrease intradiscal pressure as we apply long y-axis distraction. Looks like this. If you look at my forces there, see there I go, minus 11 to 8. I never go over 6 pounds in the neck. But you can see here how gentle that is. There I'm going about 4 pounds of distraction. You okay, doctor? That's how we would treat a cervical disc herniation. Now in osteopathy, and when you study with us, you'll be taught foramen magnum pump. That may be a new term to you. But the osteopath talks about tissue tension sense and stretching tissues. The spinal cord hangs in the vertebral column like a sack. It attaches to the dentate ligament, the foramen magnum, C1. It hangs like a sack. So in meningeal stress syndromes and in treating vagus nerve can be stimulated and relaxed at the suboccipital region. Look at the foramen magnum pump. We end every adjustment with foramen magnum pump. It can apply full spine distraction. 2 points. Number one, watch this. Taut. You okay, doctor? How many pounds am I applying here? I'm going from 4, 10, 6. That's what 6 pounds feels like, doctor. Are you okay? That's what it feels like. Another point with foramen magnum pump is it's diagnostic. When you do this to a patient, we said the spinal cord hangs in the canal like a sack, right? Dural stretch signs. If you have a disc herniation or stenosis anywhere in the spine, and you do foramen magnum pump, just say to the patient, tell me where you feel pain. And what do you think happens when I do this? And I stretch the dura over a disc herniation, over an end plate hypertrophy, over a modic type 1 end plate change. What do you think they feel? Pain. Wherever you increase neural compression, patients will feel pain. You can use this to identify low back pain. Does that make any sense or not? I hope so. You know, foramen magnum pump. So watch this. I can hold the foramen magnum. I'm not even moving it. You see the caudal section move or not? Can they see that? I'm moving this caudal section and only holding the foramen magnum pump to apply full spine, long Y-axis distraction. I can even move down to C5 and apply long Y-axis distraction. Now watch this, doctor. In clinical practice, you'll have patients come into you who live in a hypersympathetic world. They come in with upper thoracic hyperkyphosis. They got buffalo humps, but they don't have Cushing's syndrome, right? Okay. They look like this. They got neck, shoulder pain, headaches. Do cervical discs cause headaches? Absolutely. I've got papers that show surgeons who remove a C5 disc to get rid of your headache. That seems a little drastic, doesn't it? When you could do this. So when you and I treat, people come in that are really hard and tight in the upper thoracic spine. You know, you could specialize in treating upper thoracic syndrome. Is that term familiar to you? Upper thoracic syndrome? T4 syndrome? All right. When you treat these people, you just grasp the spinous process. And this is a little hyperkyphosis, aren't you, dear? Right here. Just hold the spinous. Apply lateral flexion. This spine never does this in the upper thoracics, right? No, but this never gets done. But she'll tell you that that kind of hurts good. Am I right, doctor? And when you work with these upper thoracics and you create relaxation, all that hypersympathetic day melts away. And you begin to get movement that this patient hasn't experienced perhaps ever in her life before. Then we can even make a contact with the pisiform. And let's say they had scoliosis, alevoscoliosis of the upper thoracics. You'll place the knife edge of your hand on the convex side of the curve, long Y-axis, and laterally flex in order to neural mobilize and create range of motion in that joint. Do you find that at all offensive, doctor? It's painful? Do you find it comfortable? People will love you. Next time they come in, they'll say, do that again. Okay? Next thing. I want to also thank you for being, all of you staying so late. and studying with me. It turns me on here. But when you adjust thoracic spines, I think that most of you will recognize that a lot of people don't cavitate. And it's a bad day if you make a thrust here and they've got cerebrospinal compression. Which part, anterior, posterior, subarachnoid space is affected in stenosis? Anterior. That's where the pressure builds up. And so if I'm doing this and I make a thrust and I suddenly increase that pressure on the cerebrospinal fluid, that patient is not happy. So I would offer to you that you begin to consider this, doctor. Make the contact, don't thrust. Now watch the caudal section. Just make the contact. As the disc space increases, the intradiscal pressures drop, the facets gap. If they're going to cavitate, they'll cavitate. Do you feel that, doctor? You'll get more cavitation this way than you will with this. Because if you've ever done that, and people, do you ever do that where they go, I have thousands of times. Not anymore. This is how we adjust thoracic spines. Okay? How much more time do I? Huh? You're done. I know. You could go till midnight. Yeah, I mean, you know, we're getting started and you want to quit. But are you okay?
Yeah.
It does feel good up there, doesn't it? That's how you adjust thoracics.
I think Dr. Bono has a question.
Yeah, okay. You can get up, doctor. Thank you for letting me treat you.
Thank you.
Thank you. So that's just a brief glimpse of what we do. But when you treat dish, next week I'll be in Philadelphia. And I know doctors are going to deliver papers on dish. Do you know that women have a shorter lifespan who have dish? Fact of the night, right? See, things like that charge me up. But this is a little brief outline. Tomorrow morning, I'm not sure what we're going to do. Kelly, am I going to speak to your class? Yep. Would it be all right if I show them the cervical research and more on that?
Yep.
Okay.
Everybody's invited.
Everybody's invited. Where will that be, Kelly?
We'll be in 134.
134, wherever that is. We'll be there. So I guess that there were some questions that you had for me? Oh,
I'm right
okay.
behind you, Doc.
Oh, there he is, doctor.
So we have a couple good questions. I'm going to consolidate them into group questions because there's a common theme. One of the common themes, Jim, is where do you see the chiropractic profession heading in the next couple of years?
Never before has the future of this profession been as good as it is right now. You know why? I'm looking at it. Right? Because when you come out with the knowledge, the capability, and the patient expectations that you're going to meet, success is in our pocket. And at this institution, believe me, I'm aware of Logan, okay? I know how great you are. I know about Kelly Brinkman and how great she is. And Dr. DeBono, another one of my national friends. But knowledge has a way, when properly applied, to become wisdom. Applied knowledge is called wisdom. There are a lot of smart people in this room. No, I see the future views when we double the number of people going to chiropractors, when we get rid of the fake news, like fake news, that's out there about chiropractic and start telling the truth. Are any of you from Canada here? There's a newspaper up there called the Globe and Mail and Globe newspaper. All through October, they're going to run positive stories on chiropractic. When we go up there and institute this at CMCC, I want those people. And Dr. DeBono said he'd help me meet her to do stories on this. for that great country. So that's my answer to that question.
There's a couple other, like the possible use of fMRI and studying the effect. And I think one of the things that the students, if you're not getting it to take away, when I first left school 30 years ago, it was all high velocity, low amplitude manipulation. Of course, I learned Cox technique as well, but only for discs. That's all we used it for, was discs back then. Because that's how we were taught. But I think Dr. Cox, and I think some of our clinic students should realize that. Did you see how he was using the table? Does that look like most of your colleagues are using it in the clinic? When the point I'm getting to, we sometimes get a little bit rough when we're young. Yeah. We tend to put too much too soon. And I think Dr. Cox made a valuable point of how gentle this stuff can be. Because remember what we're affecting. We're not moving bones. We're affecting the sensory system through sensory input. And if we could do that gently through the best method we can, and I think with this I was so excited when this table came because of what he just showed, those gentle neuromobilizations. That's where we're heading towards. There will always be a place for HVLA when it's needed. There will always be a place for neuromobilization when it's needed. It's our job and the wonderful research that he's done of telling us when we need it. So I think one of the comments to you too, Jim, and maybe you could expand on that, is how do we get students coming out of school to realize you have more than a hammer in your bag. You have a lot more that you can use. And sometimes, how do we teach them to do what the patient needs, not what you want to do?
Yeah, in other words, fit the technique to the patient, not the patient to your technique. That's a biggie. And I appreciate the thought in that comment. I found in 55 years of practice now that gentleness pays off. It by far gives you the best clinical outcomes, and it doesn't keep you awake at night wondering how things went of the certain patient that day. And in this point, for me, I no problem with high velocity, low amplitude. You beautiful young people, we can probably cavitate most of you, right? But you wait 20, 30 years. You wait till the football injuries and falls and things like that take a toll on you, and then you can't treat that violently. You must use a general form of care. So I say this is complementary. I have seen people that I do this to, and then they begin to cavitate. My very nice patient here, I got lovely cavitations here and in the thoracic spine without any violence. Okay? And then this last point, I decided 25 years ago that if I could help the most difficult cases, and by that I mean spinal stenosis, and Dr. Portwood's here from Smith Base up here, and I've talked to these interns, okay, over 1,000 adjustments with this man. Can you imagine her coming into practice, having done 1,000 people's under Portwood's supervision at Scott Base? She comes out a diamond. Lucky the patient that gets her. And with that, this profession has no boundaries. But I did learn a long time ago that if I can handle the most difficult, that is spinal stenosis, the average patient that comes in with mundane back pain, stiffness, facet syndrome, spondylolisthesis, Bertolotti syndrome, they become pretty boring, almost mundane, that you just have to treat, when what you really want is the 1 out of 4 that are what? 95% of the cost in human suffering in dollars. So I never want conflict over high velocity. I just want you to respect what we can do with this. So.
And I think I want to close, I want to thank so much Dr. Cox for coming. And I think it's valuable lesson, especially for the young students here. We've been around the block, you've been around the block a couple more times than I have, but
Yeah.
we're catching up.
Yeah.
And I think one of the things I need you guys to take away from this, when people dismiss a technique, that's crazy, that won't work, because mine works and it always works. Yet there's a body of research like he just showed you behind it. Who's reading the fake news there? When I first came here, I wasn't really exposed to activator. I didn't really know Arlen Fuhrer. When I started talking to him, I go, huh. But off the bat, my initial reaction was to dismiss it, because it wasn't something I was used to and something I didn't know. But then when I talked to Arlen, it changed my mind. Well, there's a body of work behind this. There is some real research and real validity, and sure enough, I use it more and more often now than I ever expected before. And the point I'm getting to the students is, all techniques work, but some techniques have a body of work behind them. It's the same way. You don't build yourself up by tearing something else down, and addition isn't subtraction. Just because you're using something else doesn't mean you have to give up something else to go away. So keep an open mind. Dr. Cox's research is phenomenal, the work behind it. To have a practitioner come to you and dismiss it offhanded, I'd have to question that practitioner, to be quite honest with you. Today, if a practitioner offhandedly dismisses activator in front of me, I have to question, did they ever look into this research and what's behind it? Keep an open mind. Not everyone's going to use Cox distraction because it doesn't fit your paradigm, but that's okay. At least you kept an open mind about it and you're not dismissing it, and you respect the people who do. And I think having practitioners like Dr. Cox come to campus, and you guys have the privilege of meeting him and exposing yourself to him, I just want to thank you, Jim, and thank you all for coming out to meet him. And please, please, catch up with him tomorrow while he's here. You don't get these chances very often. So thank you again, Dr. Cox.